Okay, we're going to start off with prolonged clotting time profile testing. This is designed to deal with unexplained prolonged clotting time test results that need further evaluation. I don't have any disclosures. We're going to, as a refresher, briefly revisit the coagulation cascade and the screening tests that are done. We're going to then look at the 8 categories of reasons why PT-PTT can be prolonged, and then look at testing strategies, specifically the algorithm we have devised and a case. This is the algorithm. It shows the PT-PTT on top along with thrombin time and dilute Russell Viper venom time. The thrombin time to evaluate for heparin, primarily the DRVVT, to begin to address for lupus anticoagulant, which is a common cause of prolonged clotting times, reflexing through mixing studies, phospholipid neutralization procedure, possibly reflexive coagulation factor assays depending on test results and available clinical information, a review of all results, and possibly selection of additional testing if clinical information or lab results suggest the need to do it, and finally an overall interpretive report is released. Here's a case. I'm going to give you the initial information about it, and then we'll circle back at the end to discuss what this is. It's a 67-year-old woman who was already known to have a prolonged PTT. It had been rechecked, it was real. You can see that it's prolonged, and a mixing study 1-to-1 with normal plasma, it appears to be inhibited. The platelet neutralization procedure, which is a way of adding extra phospholipid, does not shorten the clotting time, so it doesn't look like a lupus anticoagulant. The pro time is normal, suggesting that the common and extrinsic pathways are working. The thrombin time's normal, doesn't look like heparin or direct thrombin inhibitor. DRVVT is normal, no additional evidence of a lupus anticoagulant. The stay-clot APTT, which is a proprietary PTT reagent that has extra sensitivity for lupus anticoagulant, is prolonged, and that's a 1-to-1 mixing study, so it suggests inhibition. Adding extra phospholipid, the hex delta test doesn't significantly shorten the clotting time, so it looks like it's not a lupus anticoagulant, but there is an inhibited APTT for this person. The fibrinogen is a little elevated. D-dimer is a little elevated. So we'll come back at the end. Do you want more tests, and what would you select to do? Do you want some clinical information, which we'll also provide? Who would like the clinical information first? Okay. But I won't give it to you first. We'll come back to the end. This is actually an interesting, very recent case, actually. Okay, here's the pathway showing the intrinsic pathway coming down through factor 12 and so forth with amplification, proenzymes, enzymes, phospholipids, metals, amplification, the common pathway, the extrinsic pathway. The PTT assesses the intrinsic and common pathway, and it's more sensitive to factor deficiencies higher in the cascade, like 12, than it is to factor 2 at the bottom. The extrinsic, this pro-time test, assesses the extrinsic and common pathway. The DRVVT starts by adding a snake venom activator, a factor 10, and bypasses all of that. The thrombin time is done simply by adding thrombin to the reagent. And I'm sorry that the size of these slides is not fitting on the screen, but in the app I think you'll be able to see them. Okay, reasons for prolonged clotting times. There are 4. Could be a factor deficiency, excuse me. Could be that you have an inhibitor. Could be both, or could be neither of those. It could be a spurious test result, and we'll circle back to that. The typical approach in the laboratory to an unexplained prolonged clotting time, PT-PTT, is to do a mixing test and interpret it as the starting point for whether more evaluation is needed. Here's an example of two patients, the orange patient and the yellow patient, who have prolonged APTT. One is a factor deficiency and one is an inhibitor, such as a lupus anticoagulant. The 50-50 mix in the middle shows that the deficiency corrects because you're making all plasma factors at least 50% of normal, whereas by definition the inhibitor does not correct. But these tests are rather difficult to interpret. The mix should normalize if it's a deficiency, and that's the general rule that's followed, whereas the definition of an inhibitor is that it fails to normalize with a one-to-one mix. Incubated studies are primarily done to detect time-dependent inhibitors such as a factor VIII inhibitor. There are limited evidence and studies. The best guidelines for interpreting and performing mixing studies are in the Clinical Laboratory Standards Institute Lupus Anticoagulant Test Guidelines. Here are the 8 reasons or 8 things to think about or remember about why a clotting time is prolonged. Could be spurious, could be an inhibitor of some kind, could be congenital, could be vitamin K deficiency, could be a factor deficiency of another kind, which I'll explain in a moment, could be an anticoagulant, could be intravascular coagulation and fibrinolysis, or DIC, or it could be liver disease. So we'll address each of these briefly and then circle back to the case and the algorithm at the end. These are really common. The bottom of the slide is supposed to tell you to be aware that they're very common, and you should always think spurious when you get a result that you don't expect. The typical approach for the clinician is to repeat the test with a fresh draw and see if that's true, or was it a heparin line contamination, or was the clotting evacuated tube incompletely filled, and so forth, or was it EDTA or heparin anticoagulated or serum. So these are very common, and the laboratory and the clinician needs to be aware that for coagulation testing, spurious is the #1 thing to think about, although real is real too. Could be transfusion, a difficult sample collection, difficulty analyzing the sample because of hemolysis, and so forth. So lots of things can go wrong with the sample and give you an abnormal result, and we'll have some examples of cases in this presentation. Vitamin K, the coagulation vitamin. It's very important, and despite being fat soluble, we don't store very much, so you run out of it very quickly. The typical pattern of coagulation abnormalities is that the pro time is more prolonged in the PTT. It responds to treatment with vitamin K, which is a pretty good test, or if necessary, you can measure factors and so forth to see the typical pattern. Anticoagulants, they're more and more ubiquitous. They're good for patients, usually. The coumarins, the heparins that act in an antithrombin-dependent manner, the direct thrombin inhibitors, the direct-acting factor Xa inhibitors. We'll just touch briefly on these. The coumarins, the typical test results, as you well know, the pro time is more prolonged than the PTT, and if you know the patient's on warfarin, that explains it. There are unusual situations, as mentioned at the bottom, about rat poison and surreptitious. The PTT, as you know, the typical effects are to prolong the PTT and not the pro time because it has a heparin neutralizer in it. In the laboratory, many laboratories use a thrombin time test to screen for whether a sample has heparin, and nowadays direct thrombin inhibitor. The differential diagnosis of a prolonged thrombin time is listed here. In our laboratory, we reflex to a reptilase time. The usual cause is heparin, and so the reptilase time is normal, but if they're both significantly prolonged, one thinks of dysfibrinogenemia. The tests are not very sensitive to low fibrinogen. It has to be usually below 100 before they become prolonged. Lots of other anticoagulants have big impacts, and our speakers will be talking about some of these anticoagulants and how they can potentially lead us astray. Liver disease. Well, the liver disease clotting pattern, pro time more prolonged usually than the PTT. The K-dependent factors are low, as well as essentially all the other factors made in the liver except for factor VIII, which comes from liver endothelium. Patients bleed more than they thrombose, but they can do both. Congenital hereditary, typically single factor deficiency. There are some exceptions. The hemophilias A, B, and C are distinguished by prolonged APTT if the factor level is low enough, but the PTT is not very sensitive to factor 8 or 9 deficiency, so you actually need to measure them to identify or exclude factor 8 or 9 deficiency. Factor 7 is distinguished by having a prolonged prothrombin time, but normal PTT, and then the others, all of which are quite rare, typically would have both a prolonged PT and PTT, the PT perhaps more impressive. Then you can have factor deficiencies on an acquired basis, either multiple, as we've already seen, or single factors, which I'll show you something about. Here are some patterns: the liver disease pattern, the vitamin K deficiency pattern we've talked about, DIC consuming fibrinogen, factor 5, factor 7, consuming plasminogen and antiplasmin, and so forth, antithrombin, and some other patterns that are mentioned there. Single deficiencies we think of as possibly hereditary congenital, but occasionally they are acquired. Factor 2 or 10 can be targeted by lupus anticoagulant antibodies and cleared from the circulation. Factor 10 can also be cleared by systemic AL amyloidosis by being absorbed into that abnormal tissue. Factor 5 can be a little low sometimes in myeloproliferative disorders, and then acquired von Willebrand syndrome, which we'll hear about, can have low factor 8 and VWF. ICF or DIC is something commonly considered and difficult to evaluate. Here is the pathway, the main proenzyme plasminogen, and its active form plasmin, which degrades fibrin to fibrin degradation products. Fibrin binds plasminogen. When fibrin is laid down from generating thrombin, it binds plasminogen, and it binds tissue plasminogen activator to bring these in apposition and to physiologically activate the fibrinolytic pathway. So fibrin is the platelets of the fibrinolytic system, as platelets are for the procoagulant system. So it's a physiological state that can become pathological, and some of the pathologic conditions are mentioned more on the right. The patterns can be acute. What we often think of can be chronic if you have a chronic intravascular situation such as a intracardiac thrombus or an aortic aneurysm. Can be mild or severe, can be compensated, meaning the factors are essentially normal. Bleeding is more common than thrombosis, but they both can occur. So the typical laboratory findings: the platelets are consumed, the pro time is more prolonged than the PTT, the fibrinogen is consumed, the dimer is elevated, telling you that you made too much thrombin and that activated plasmin, or you have increased soluble fibrin that hasn't quite assembled yet to become fibrin D dimers. Supplemental tests can be done if necessary. You consume antithrombin, you consume some of the factors, and so forth. The tests, though, are so commonly provoked by physiologic and pathologic conditions that by themselves they're not diagnostic. You need a clinical assessment and a clinical assessment tool, and we still yet lack really effective pretest probability tools for suggesting DIC. The tests are the probabilities are mostly based on the combination of laboratory findings. This is something rare, but it occurs where you activate fibrinolysis without generating thrombin first, and the main clinical situation we've encountered is systemic amyloidosis, prostate cancer, and some others. Last, inhibitors. Specific factor inhibitors are antibodies that neutralize factors, primarily factor 8 and some others which we'll mention. The nonspecific inhibitors means they're not specific for a particular clotting factor. Lupus anticoagulants are, quote, antiphospholipid antibodies, really antibodies to phospholipid binding proteins. Dysproteinemias monoclonal gammopathy, myeloma, Waldenstrom's, and so forth. Sometimes these antibodies can interfere with in vitro and sometimes in vivo coagulation, and then global inhibitors like heparin, direct thrombin inhibitors, and so forth. So there's your differential of inhibitors. Then a word or two about each of them briefly. The factor VIII inhibitors are by far the most common, the others less common, as listed here. Factor VIII inhibitors, of course, occur in individuals with severe hemophilia A, but they also arise as autoantibodies, most often in sort of old, healthy people who come in with prolonged APTT, hematomas, bruising, and so forth, can occur postpartum. Here's where the incubated mixing test is useful to try to identify time-dependent inhibition. A test that we developed a long time ago at Mayo Clinic uses the incubated test in a factor VIII assay system. So on the right, you can see the immediate mix. It's a 4-to-1 mix of plasma from the patient and normal plasma. You can predict, where it says expected, the results you would get, and you compare the results you get with the predicted result, which should be within 1 or 2%. Then you test after incubation and see if the results you get matches what you expect. In this case, it doesn't. There is partial progressive inactivation of the factor VIII activity in normal plasma. On the left side, you see that the patient in this case has undetectably low factor VIII activity. It's less than 1%. Then this test, which is our factor VIII inhibitor testing algorithm, measure the factor VIII activity, perform the screen. We then do the Bethesda titering assay, which is a 2-hour incubation of a 1-to-1 mix of serially diluted patient plasma, and you can titer or find that dilution that inhibits half the factor VIII activity. Lupus anticoagulants, we'll hear more about that. The cardinal criteria are prolonged, inhibited, phospholipid dependent, and to evaluate for other confounding things that can cause prolongation and false results, and to do serologic testing for beta-2-glycoprotein-1 antibodies with or without cardiolipin on them. One of our speakers will be discussing this in more detail. Dysproteinemias sometimes can inhibit clotting time tests and sometimes can cause bleeding. In our experience, most of these individuals are asymptomatic, but some of them do have bleeding. And we'll come back to that later. So the differential diagnosis of an inhibitor, more or less in order of probability, is it's an anticoagulant. It's heparin. It's rivaroxaban. It's Eliquis. It's direct thrombin inhibitor. If it isn't that, it's a lupus anticoagulant. If it isn't that, it could be a specific factor inhibitor, especially factor VIII. If it isn't that, it could be a monoclonal antibody. And if it isn't that, it could be markedly elevated fibrin degradation products or D-dimer, although those usually only cause mildly prolonged pro-time, not so markedly prolonged. So there are the 8 things to think about in your differential, especially that spurious one. I was going to skip that one and show you the algorithm again, and then we'll circle back to the case. Where we had gotten to with this case is we'd done a PTT, a mix, a platelet neutralization procedure. We had done a pro-time and thrombin time. They were both normal. We'd done a DRVVT. That was normal. At the bottom, we'd added a stay-clot LA test. So I won't tell you the clinical information. I'll tell you the next tests. So we've ruled out a lupus anticoagulant. Yes or no? Yes? Probably. We've got 3 tests that don't look like lupus. We have ruled out a factor inhibitor. Yes? No? No. We haven't ruled out a factor inhibitor. This could be a factor VIII inhibitor or something in the intrinsic pathway. Could it be an anticoagulant? Well, doesn't look like warfarin, doesn't look like heparin. The thrombin time is normal. It doesn't look like a direct thrombin inhibitor. Could it be one of those evil factor Xa inhibitors? Well, it might be. Okay. So we haven't ruled out a specific factor inhibitor, and we haven't ruled out an evil anticoagulant. All right. So let's rule out the factor inhibitor. The patient plasma inhibits the APTT-based assays, but the more you dilute the patient plasma, the more apparent activity. So the factor VIII was at least 191% and so forth. So it's not a factor VIII inhibitor. Therefore, what is it? It's not lupus. It's not a factor VIII inhibitor. We're now down to it's a direct anticoagulant, or what? Okay, we're toward the bottom of this list. I'm going to tell you that the patient was not on anticoagulants. This is a woman who had a monoclonal gammopathy for a few years, 3 or 4 years. It's only a small amount. It actually was 0.4 when she was off of steroids. She had a troublesome pruritic skin rash. She had a little bit of bleeding, but that wasn't the main issue. She was felt to have a monoclonal gammopathy of unknown significance, and because she was so disabled by her skin rash that had not improved despite courses of corticosteroids, a decision was collaboratively made to treat her as though she had myeloma with Velcad, dexamethasone, and Revlimid to see if that cured her skin rash and her PTT. I don't have the answer to that because this is a very recent case. Okay, we have time, I think, for a question or two if anybody would like to detour from the normal path. I saw this at ASH last year. This was on Union Square, and I just couldn't resist taking a picture. Questions? You've got it all. You understand about prolonged clotting times. Okay. Thank you very much.